So we are moving forward to our next talk, and our speaker is Dr. Vinit Baliyan, and he will be talking about pre-procedure planning for TMVR.
Well, it's a pleasure to have Vinit here, who is now working as a staff radiologist and division quality director of Cardiovascular Institute Imaging at Massachusetts General Hospital at Harvard Medical School. And previously, he was a student of our institute. I'm proud to say that. And his interest in cardiac CT, and we are going to hear him speak about pre-procedure planning in TMVR.
Hello. Yes. Yeah, thank you, ma'am, for a kind introduction. And I would again like to thank the association for the invitation for this talk. And it has been a wonderful experience again. Like I was in Goa last year, had a fantastic time. And this time I think experience was even better. So yeah, this is my last talk for this conference. So I'll be heading away after this talk. But it was lovely to meet everyone. So yeah, let's start. So pre-procedure planning in TMVR. So I'm going to spend time, like next 20 minutes, on reviewing the anatomy of the mitral valve, and then indications of TMVR, devices, and different approaches. And then I'll touch upon main focus of topic of interest, which is cardiac CT and TMVR planning, and I would go through protocol that we use, and pre-procedure evaluations, basically the measurements and venous access, and unique challenges, and some case examples of unique challenges and pitfalls, and then conclusion. So mitral valve, it's a atrioventricular valve on the left side of the heart, between the left atrium and left ventricle. It's composed of the annulus, two leaflets, and subvalvular apparatus, which constitutes of chorditendinae and papillary muscles. So this is an explanted image from a publication. This is a parallel kind of similar plain CT image, and we can see there is an annulus which has some calcification. These are the leaflets. The valve is closed, so it's probably systole, and we see papillary muscles and chorditendinae. So looking at the valve on a short axis image here, a valve is composed of, as I said, two leaflets, anterior and posterior, which are again subdivided into A1, A2, and A3 subcomponent anteriorly, and P1, P2, P3 posteriorly. And there are two commissures, which is medial and lateral commissures. So looking at the valve annulus, so it's a D-shaped annulus. The middle image, short axis view, we can see it's the anteriorly there is aortomitral continuity, and I mean medially towards the septum, anteriorly, laterally, and posteriorly the valve is attached to the intima of the left ventricular myocardium. So it's a D-shaped valve. If you look at the cross section here, like there is a anterior fibrous trigone, posterior fibrous trigone, and then the leaflet attachment to the myocardium, which forms the D. If you look at the valve from lateral aspect, if we view from this side, then it's actually not in a single plane, it's a saddle. So that is an important caveat to remember. So indications of TMVR are basically any disorder of the valve, which are usually either regurgitation, stenosis, or a combination. And in individuals who cannot have either surgery or a minimally invasive edge repair or mitral clip, all those become the indications for TMVR. Also, failed bioprosthesis, like a bioprosthetic mitral valve, which has become dysfunctional, is another indication, which is called as valve-in-valve TMVR. That I will not cover that much of that valve-in-valve because it's a part of another talk. But I'll briefly talk about mitral annular calcification, or valve in MAC, where a dysfunctional valve is associated with mitral annular calcification, which has unique challenges and complications. So first, let's talk about what are the contraindications of the mitral clips. So they are small valve orifice, rheumatic heart disease, and mitral valve prolapse with or without flare leaflets. In this image, you can see there is mitral valve prolapse. we can see flare leaflet, a patient with rheumatic heart disease with thickened, restricted mobility of the leaflets and calcification. So all these become candidates for TMVR. So as I said, there are three scenarios where TMVR is done. One is native valve non-calcified annulus, which is the most common. Then we have valve in MAC, where there is a large mitral annular calcification. And then there is a valve in valve where we are placing a device inside a bioprosthesis. Looking at the approaches that are used for placement of the valve, there are two, transseptal and transapical. In transseptal, we go through posterior inferior interatrial septum, perforating the septum, and then the device is deployed at the valve. And similarly, in a transapical approach, we go through the apex, and then device is deployed. Looking at the devices, there are a large number of devices available, and the number is growing by every year. But the one that is approved by FDA is the Edwards Sapien 3 device. But all the others are mostly in the trials, and they're not currently approved by FDA. But devices can have preferred route of deployment. Some are favored to be delivered by transseptal. Some can be delivered by both, and some can be just transapical. So coming to pre-procedural planning, so CTA is the modality of choice, and we at our institute use a standard optimized protocol for all our valve planning. I'll touch upon that. And then from pre-procedure planning standpoint, there are two things we need to look at. One is basically the annulus, including the left ventricular outflow tract, and second is the vascular access. So why CT? Because CT can actually show you the diagnosis if there is a mitral annular calcification, or if there is a rheumatic looking valve, or it can show you prolapse and flare leaflets. But that is not the main intent behind these studies. Most importantly, it can act because of high spatial resolution. It allows accurate sizing, and then it can show peripheral access. There is heterogeneity how people deal with this. Like at our institute, we get a body CTA with all our valves, valve planning cases, because it's we believe is important to look at the vascular access. And then CT can always show you unexpected findings like a malignancy, which may affect the candidacy for the valve placement. All right, so our protocol includes like a topogram of the chest, abdomen, and pelvis. We start with a non-contrast gated CT of the heart, and then we do a non-con of the whole chest, abdomen, and pelvis, which is followed by a gated, retrospectively gated acquisition of the heart only, followed by a CTA, flash CTA of the entire chest, abdomen, and pelvis, and a 2-minute delay. And we use this for all our valve planning. And the rationale is we sometimes same patient has more than one procedures done, and also having different protocols kind of disrupts the workflow. Sometimes indication is wrong, and then you have to do it all over again. And the only problem with this protocol is radiation dose, which is in excess of 10 millisievert of median doses. But these are usually old individuals, and radiation is not that much of a concern. So looking at our contrast injection protocol, so we use a triphasic injection, so which first is upfront pure contrast, followed by a mix of either, for left heart indications, we do a 20% mix. For right heart indications, we do a 50% mix, which is followed by pure saline. And it generates, like if we give like a mix of 50%, then right heart opacification is also great. And we do a retrospectively gated scan with no pulsing, because we are looking at, for aortic, you can do systole only, but for mitral and all the other valves, we need measurements of both systole and diastole. So functional images are necessary. After we have acquired images, what are the things that we need to report? Basically, so as I said, there are two axes. One is transseptal and one is transapical. So we need to look at those areas. And then there are device-specific angular measurements. And then we also need to look at central veins, which mostly the access is venous through the IVC, so we need to look at that. So looking at the access points, so for septum, we need to see if there are any issues with the septum, if there is a defect or an aneurysm, or a PFO, then or a lipomatous hypertrophy, surgeons will like to know that. And for transapical, we just see which intercostal space is the closest to the apex and what is the orientation relative to the apex. For annulus measurement, the accurate sizing is critical. This is the most important thing that we do. And if you look at different devices, the measurements slightly differ. If you look at this, some of them want area, some want different diameters, some want perimeters. So, but to make it kind of comprehensive and one fits all, we do all these measurements for everyone. And accurate sizing is important because if you oversize, you rupture the annulus and maybe injure the coronary left circumflex, which is very close to the annulus. And if you undersized, those individuals are then may have leaks or dislodgement or embolization of the device. So looking at all the measurements, so we measure the annulus perimeter in two ways. One is a 2D measurement, like you kind of draw a line between the anterior fibrous trigone and posterior fibrous trigone, and then you follow the leaflet attachment all around and you draw the circle, which gives you a 2D measurement. But we also do a 3D measurement where this point of attachment of the leaflet and myocardium is tracked throughout the valve circumference, and it's basically not in a single plane, and the reason being that because it's a saddle-shaped valve. So this measurement is usually a little bit different. Our surgeons like to know both types of perimeters. And then there are different diameters. There is a trigone to trigone distance, the distance between the anterior and posterior fibrous trigones. And then there is a parallel line to this plane, which goes from the anterior valve commission to posterior. Then that's the intercommissural distance. And then if you measure the distance between the trigone to trigone line to the lateralmost edge of the annulus, then it gives you septal lateral distance. So looking at the other things that we need to report is LVOT. So this is the most critical thing that is impacted by device placement. You can see in this patient, they have a TAVR and also a TMVR. And you can see if you place this device, then it can go very close to septum and can obstruct the LVOT. So to avoid that, we do some kind of simulation-based measurements to see how much narrowing the device will going to result in. And this is the image that shows that simulation. So we place this device inside our software, and then you can see how much is the distance and area that is left behind after that device has been placed. One important thing to remember is these devices can be deployed in different configuration relative to the annulus. Most commonly, they use 80% of the device below and 20% above, but they can also use 60-40. So it's important to, as you can imagine, the farther the device goes into the ventricle, more are the chances of obstructing. So 60-40 and 80-20 will result in different degree of obstruction. And so it's important to know what is the plan for the patient. So looking at how these measurements are performed, this is an image in systole, and we can see the simulation of the device. And you can see that this is the approximate edge of the device by the simulation. So this is was the LVOT area before the device simulation, but after simulation, we measure the area outside, and in this case, we can see area reduced from 5.8 centimeters squared to 2.9. That is still good. Everything about more than 1.7 works well. Even some surgeons go as low as 1.2. But those are the important numbers to remember. And it's important to know that narrowing will be maximum in systole, so that's where we measure it. And in systole, that's where the maximum amount of flow is. So this graph kind of shows how new LVOT area changes during cardiac cycle. Additional measurements that we perform is anterior leaflet length, which is important because you can see when the device will be placed here, this leaflet will kind of we covering the device anteriorly like a blanket. So that is important. If leaflet length is more than 30, that predisposes to obstruction. Another thing is angle between the aortic and mitral annular planes. And you can imagine the narrower this angle becomes, there are more chances that this device will go towards the septum. So more acute angles predispose to obstruction. Another thing we look at is the septal thickness, because in some cases, if septal thickness is increased, like in patients with HCM, you can tell surgeon that this could be partly resulting in the obstruction of the LVOT, and then they can ablate the septum to create more room for the device. Other factors that you can consider reporting is the fluoroscopic angles for the surgeons, and you can also, on these angles, measure the distances between the septum, intraatrial septum, and the annular plane, and also the apex and the annular plane. All these measurements are helpful to the surgeons to reduce the scan time, procedure time. Another aspect of the reporting is central venous anatomy. So mostly there is a peripheral venous access through groin. So basically we need to look for the patency or any anomaly or obstruction in the inferior vena cava and iliac veins. And I have a few examples here. And this is the first case where there is an IVC filter and everything below that is obstructed. Of course, that cannot be used for access. This is one of the older kind of surgical IVC occluders, which is called as Adam DV's device. So sometimes these are old devices, but you can still find them in some of these older individuals. And another thing to look at is the variant. So in this first example, there is a left-sided IVC. On the central one, there is a duplicated IVC. On third one, there is, which is probably the most likely to result in challenges, is the interrupted IVC. Here you can see IVC kind of continues at the adjacent vein. So definitely this cannot be used as access for device placement in this individual. This is another example where there are anomalies in both SVC and IVC. Here you can see there is a left-sided adjacent vein and left-sided SVC without a right-sided SVC. And then you can see IVC also is anomalous. You can see the native inferior cavitary junction is kind of diminutive, and there is another IVC more anteriorly. So all these, because we do venous imaging in everyone, we kind of look for these things, and I think this is important. So looking at some of the challenging cases and scenarios, I will go through some contraindications, some challenges with the small neo LVOT and how surgeons deal with them, and then some of the procedures and new techniques that can avoid neo LVOT obstruction. And I'll show a challenging case of valve in MAC with some complication. So these are the contraindications for the device. So if there is a unileaflet valve, then there is not enough tissue posteriorly to hold the device. If there is a large aneurysm adjacent to the annulus, again, it can result in device dislodgement. And if there are the annulus size is too small or too large, all these devices come in specific sizes. We use Sapien devices. They, I think, come in 26 millimeter and 29 millimeter. So if annulus is smaller and larger than that, then you cannot do procedure on those individuals, or you look for specific devices that can fit them. So this is an example of small neo LVOT in this patient who had septal predominant hypertrophic cardiomyopathy, and you can see a very thick interventricular septum, and we have the annular measurements here, and you can see the neo LVOT is very small. So that area after the simulation is 1 centimeter squared. So that is below the lowest that surgeons will accept. But in this case, because septum is thick, you can kind of pull that lever. And this patient had an alcohol septal ablation, which created a little bit of room. They increased the area by up to more than just about 1.2, and this patient successfully had a procedure. These are some other techniques. There is a neo skirt device in which the device is a metallic cage covered by a fabric, which is called a skirt. In neo skirt, the skirt is missing anteriorly. So anteriorly, you have perforated device through which blood flow can go. So it increases the room that is available. So you can do these measurements. In this case, you can see neo-LVOT area was 0.5, and with a skirt neo, you can increase it up to 2.1. So that is helpful. Another thing is a lampoon procedure, where in patients who have long anterior leaflet, so leaflet does the same thing as the fabric of the skirt of the device is doing. If there is a very long leaflet, that becomes the real challenge. The valve itself is not obstructing, but that blanket of the anterior leaflet, which is covering the device, is the problem. So lampoon is basically the lacerate this anterior leaflet, which kind of creates room and prevents LVOT obstruction. And this is an unfortunate example where all these measures failed and the patient ended up having a very small knee LVOT and symptomatic aortic stenosis or subvalvular aortic stenosis. So looking at valve and MAC, so valve and MAC is challenging because there is so much calcium and this annulus is not smooth and it's bumpy. And also there might be loose fragments. When you place device, they can embolize. And also because there are these kind of crevices in the periphery, once you put a device, it doesn't snugly fit the annulus and you can leave behind regurgitant orifices. And there is some literature based on, there are ways to quantify how much the MAC there is, and there is a score-based system where you give points to thickness and circumference and involvement of trigone and leaflets and so on. And they say if MAC score is more than 7, then it predisposes to complications of embolization and migration or leak. This is an example. So this patient, this is the pre-procedure image. The patient already had a TAVR and they wanted to do a TMVR, and then you have large amount of mitral annular calcification. After the device was placed, there was a leak, and which was localized by echo towards the septum inferiorly, and we could reproduce that on CT. You can see there is a contrast channel outside the device, which is continuous between the atrium and ventricle. And then this patient had a procedure percutaneously. This hole was plugged, and it took care of the leak. And you can see on follow-up CT that's the implantable kind of device sealing this area of leak, also seen on this plane. All right, so conclusions. So as we know, there are increasing transcatheter valve options for not only mitral, but all the valves. And we need to be aware of these procedures and understand our role in these procedures. And if we speak about TMVR, then CT is the modality of choice as for all the other ones. And standardized imaging protocols are helpful. And assessment of valve annulus and access are key for procedure planning. Neo-LV OT measurements are critical if we want to avoid complications of LVOT obstruction. And we need to be familiar with septal ablation, lampoon, and skirt neo because these are helpful in avoiding obstruction. And then valve in MAC is prone to complications of leak and embolization. We need to be mindful of that. Thank you so much. And I would like to thank the members of cardiovascular division at MGH, and especially our 3D lab who does all the measurements for us. And they kind of teach us every day and keep us updated to all new developments in this rapidly evolving field. Thank you.
Brilliant talk. Thank you, Vinit. That was excellent. That was really very well covered, and I think it's really new. And TMVR in India is really happening only in a few centers. And I just want the take-home message from this is just remember one thing. While most things I believe that we should be doing it manually, this is one valve which you can't really size manually because the problem is that it's a saddle-shaped valve and it's a D-shaped valve, and we've got to take the entire up-down angle into consideration when you're measuring. So you really need a software here. So which software do you use?
So we are using TerraRecon for most of these cases. And we heavily rely on our 3D lab because they do a lot of these every day. And if you're not doing many of them every day, then you kind of are not confident what you're doing. So it's important that one person, or we have 3 of them, 3 individuals, 3 technologists whom we have trained, and they do all the measurements. So it's important to avoid like inter-observer variations, and because they do them for all of us, they end up doing more than what we would have done individually.
Absolutely. Yeah, so this is one place where,
Thank you, Dr. Vinit. It was a wonderful talk. This is just a concern that I wanted to raise. That when we are doing these cases at our institute, so like sir showed us, and I wanted to
Why
inquire
don't you
about.
identify yourself so everybody knows?
I'm Dr. Nishu from Safdarjung Hospital. So when sir was showing all these cases, he was talking about the software. So what is happening at our place is that we are just scanning, we are dedicating so much time to our measurements and all. But what happens is that the companies who are providing with these replace walls and all that, they take the cases in CD from us, and they provide their own measurement, because obviously the as I showed their measurements are very accurate, and they show it very nicely. So basically this field is being snatched away from us, sort of, so because we don't have the software. So I just wanted to know if IACI can do something about it, about the software. I mean, I'm not saying that you provide us the software, but I think this is an area of concern, that everything is being snatched away from us.
I think you've put up a very, very excellent question, and it's a very important point. And I think not only IACI, but I think even IRIA needs to get into the picture. And possibly we should be having a pay-per-use sort of a model, which is given the total number of people who would be interested in using it. Maybe we can get it at a much concessional rate. So for sure we'll have to buy it. Otherwise because a lot of us are not in centers where, or hospitals where you can have free access to softwares that are needed, and the software is also evolving very quickly. And because they keep getting upgraded, and sometimes even if you buy one, it's not relevant after some time. So I think we need to all get into some sort of a cloud-based software, or which is getting upgraded by the day, or by as and when the new developments happen. And we should be able to purchase it on either a pay-per-use or a annual model. And if there is a large number of people, maybe we can actually bargain it down. So for sure, that, because this is exactly what I said, even for the tower, where if we do not read it ourselves, it will go out of our hands, because it will go into either the tech hand or somebody who's not capable and not really adequately taught, or hasn't been informed. So there's no point having these technicians reading it for us. We need to have it read by the radiologists.
Because not even in this field, I mean, not even in this the cardiac thing, even in neuro also this is happening. For stents also this is happening.
Yes.
And they're charging a lot for a single case.
Yeah, I agree.
This
Of course,
is-
software availability. You want to?
No, this is true everywhere.
yeah.
For the TAVR, for the stent grafts, cardiologists are not conversant with the radiological images. So what they do is they get a CT done from outside, put it in a CD, give it to the company people. He tells them put this stent graft this size, and they go ahead and do it, because they are not conversant with planning. They don't know how to size their device. So it's an easy thing for them. And how to stop it, because your patients are coming from the cardiologist. Now that is a difficult job.
Yeah. Yeah.
We can.
Yeah, those are relevant concerns, and I agree. Software availability needs to be sorted, and also we need to uh, train ourselves so well that there is no better alternative than us. And as volume increases, then our expertise goes up. And as Sandeep already mentioned that earlier, even at our institution, these measurements were done by vendors, and then because we started doing them in larger and larger volumes, and there were discrepancies, and we ended up kind of being right on those discrepancies, and now our surgeons rely us more than. And also equally important to keep that relationship with your cardiologists and surgeons, which is of course goes a long way.
What's one scary point is, if the softwares get this good that we really want them this bad, it just means that AI is on the way. So just remember that. Okay. Thank you,
All right.
Dr. Vinit. That was
All
an
right.
excellent talk.
Yeah.
Absolutely a pleasure to have you here.
Thank you so much.